Thank you all again for coming along to the Drug and Alcohol Research Innovation Active Learning Network, DARIA. I'm Chris Tronti and I'm chairing today, and today I'm lucky enough to be joined by one of my colleagues, Dr. Craig Rodgers, one of the addiction medicine specialists at St. Vincent's, but also GP, and who is the clinical lead for our FOPiT study over here at St. Vincent's Hospital, which is looking at the feasibility of opioid injection trial, basically the implementation of time-limited parenteral hydromorphone in people with treatment-resistant injecting opioid use disorder. Promises to be a very interesting and certainly very relevant topic, whilst I appreciate sometimes people in our more regional communities may not have access to such trials and research. I think that it's good to be abreast of these things and to have some awareness of options that may be out there in the future for patients who are treatment resistant. So without any further ado, I'll hand over to you, Craig.
Thank you, Chris. Yes, doing very little GP these days. One sort of guest appearance Saturday morning once a month. The good old FOPiT trial has been taking up a lot of time recently, particularly over the last sort of few months as we've been getting it off the ground. So yes, it has a very long name, implementation of time-limited parenteral hydromorphone, people with treatment-resistant injecting opioid use disorder, but affectionately known as FOPiT. And we'll talk a little bit about how the trial came to be. So we do know that Australia has a sort of well-developed opioid agonist treatment program, but I'm sure we've all seen that there are still plenty of people that either don't respond well to methadone or buprenorphine, or while they're on treatment, continue to inject. There's been research in this area. Nicholas in 2009 published some data looking at about 5 to 15% of people engage in treatment continue injecting street opioids and experience severe harms. This is sort of actually backed up a little bit by some surveys from the Medically Supervised Injecting Centre. One of their surveys showed that about 10% of their clients still attending the injecting centre had actually first registered in 2001, 2002. So indicating that there are some people who have a prolonged history of injecting opioid use. They also found in a sort of more recent survey that up to 43% of people attending injecting centre were actually on methadone. Then a further 35% had been on methadone previously. So a larger number than what was reported earlier in 2009. So there's sort of been talk of supervised injectable opioid treatment in Australia for a long time. We were a little bit slow in the mark in terms of introducing it, and it's been done overseas, and it's now recognised as a second-line treatment option for individuals who persist injecting opioids despite access to some form of opioid agonist treatment, usually methadone in the past. So it involves prescribing either pharmaceutical heroin, known as diacetylmorphine, or more recently hydromorphone for people who persist with their injecting. In some of the studies, depending where they've been done, some of the participants also received oral methadone. They either had to be on methadone or they could have methadone as an adjunct to their injectable treatment to get them through their dosing periods. I should just sort of highlight that COT is sort of the preferred term for this sort of injectable treatment these days, supervised injectable opioid treatment. Why do we offer these as a treatment? Injected opioids, they're more rewarding than standard OATs, oral OATs, or even injectable OATs, and can attract more people potentially to treatment and maybe hold them in a more structured treatment program, giving them more chance for methadone and the other OAT to be effective, and more chance to sort of achieve some goals that assist in their treatment. So therefore integrating COT into our maybe existing public clinics here in Australia could be another sort of sustainable and accessible approach to managing some of these clients who are not responding to traditional opioid treatments such as methadone and buprenorphine. So yes, it's not a new idea. We're not exactly doing anything sort of groundbreaking in that respect worldwide. As I said, it was actually proposed to introduce a heroin trial back in the late 90s in the ACT. However, that would have involved introducing or sourcing prescription diacetylmorphine, which would have involved a change in federal legislations. And at the time, the government wasn't supportive of that. So the trial didn't really get off the ground, but there's been a lot of debate since in various circles, and certainly in the early 2000s, there's a paper sort of looking at, hey, why don't we use hydromorphone? It was the Swiss, I believe, who sort of first looked at heroin maintenance programs, so comparing injectable heroin with traditional methadone programs, and found reasonable results. I'm not going to sort of talk about all the results in detail. Then there were sort of two sort of larger studies in the sort of mid to late 2000s. One of them was in North America, which ended up essentially being in Canada, not other parts of America, called NAOMI, North American Opioid Medicine Initiative, I think. This is not necessarily the title of the paper looking at the results, but I'm sort of keen to read this now, having or read this a bit more in terms of having dealt with the FOPiT study for a little while. So certainly we've had our own trials and tribulations, and we can compare notes. So that was what's happening in North America. And then in the UK, there was a study called RIOT, randomized injectable opioid treatment trial, looking at injectable methadone as well as injectable heroin versus standard methadone. So these studies, as I said, have shown sort of benefit, and hence a reasonable second line approach. There was another sort of study done again in North America, Vancouver, where they actually compared hydromorphone with diacetylmorphine, and they sort of found that probably about 50% of the participants couldn't actually tell that they were using hydromorphone. So about 50% who were on heroin thought they were getting hydromorphone, and vice versa, 50% on hydromorphone thought they were getting heroin. So where diacetylmorphine isn't able to be sourced, then hydromorphone is a reasonable alternative. So what is a little bit different about FOPiT compared to these other sort of studies? Most of these studies have investigated the effectiveness of injectable treatments versus methadone, and have not necessarily tested the effectiveness of what we call time-limited CEOT. A lot of these studies were randomized controlled trials that went for 6 months, and then occasionally they would sort of do a little bit of follow-up of certain cohorts, but haven't sort of really followed people over a longer period of time. What a lot of the studies have also shown is that most of the benefit does occur in that first 6 months of treatment. Some of the cohort studies that have followed up people at other sort of time periods haven't sort of really seen any great improvements in sort of drug use or other social markers. So the sort of the data currently sort of suggests that moderate term CEOT with transfer to methadone at a certain point in time potentially is a more effective use of resources than just sort of indefinite maintenance with injectable treatment. It is more expensive to a degree to run with more observations, so ongoing treatment over years and years and years can be a little bit more problematic in terms of cost. So participants in the FOPiT study are offered parenteral or injectable hydromorphone as an adjunct to methadone or some other agonist treatment if they're already on it, for up to 2 years, so 24 months. followed by transfer to methadone or other agonist treatment. So probably about 18 months of treatment, we'd sort of suggest to people to sort of scale down their hydromorphone and scale up their other OAT, or, you know, people at the end of 2 years may decide to go back to injecting heroin, which I guess is not ideal, but this is the idea of the study. The FOPiT study's been a long time in gestation. It is sort of been led largely by Uniting, who run the Medically Supervised Injecting Centre, who approached St Vincent's and ultimately University of New South Wales to conduct the study. So the project's a partnership between those three groups, with our main investigators being Nadine Ezard, who is the director here at St Vincent's. James Bell is an eminent drug and alcohol physician in Australia who's got a lot of overseas experience with CEOTS. Darren Roberts is one of our other sort of past addiction specialists and works in clinical pharmacology as well. And then Alison Ritter and College Law from University of New South Wales. Krista, I think you're on that box now. Sorry, I haven't updated that. But associate investigators, Marianne Jauncey from the Injecting Centre, Vendula Balakova is also from the Injecting Centre, has worked on CEOTS trials overseas. Krista, co-director of NCCRED, Nicola Sirius and Adrian Dunlop, Australian addiction medicine specialists. Nicola Sirius has a lot of experience in this area as well. And then John Strang, Wim van der Brink and Eugenia Oviedo Yoquez, our sort of overseas experts, I guess, in these studies. So the study itself, it's smallish. It's a single site, just at Rankin, uncontrolled. So we're not looking at sort of a placebo arm at all. Everyone's getting open label or real drug. So I guess it's more called an implementation study. So seeing how this works in an Australian setting. Ideally aiming to recruit sort of 20 to 30 people who are resistant to current opioid treatments and continue to inject. They're offered parenteral hydromorphone, so injectable, as an adjunct to any other opioid agonist treatment. Initially it was mainly thought to be methadone, but we have got a couple of participants on buprenorphine sublingually and one on depot buvidal. And at the end of the 24 months, they hopefully will continue in some form of agonist treatment, and we will follow them up for 3 months after that sort of 2-year period. So the idea is really to sort of see where they are 3 months after stopping hydromorphone. So that could be earlier in the piece if people decide to drop off a little bit earlier. So people, opioid injectors, either not previously responding to conventional treatment, or they may be on treatment and still injecting. We're looking at the feasibility of this in the Australian context, the safety of it, as well as the cost of this sort of time-limited approach. We're going to assess feasibility by looking at recruitment, how many people were recruited, but also potentially people that we have, say, put their names forward and haven't been able to recruit, or the numbers of people really, how we sort of stabilise them on treatment, and then the transfer of people to other opioid treatment. So either within the 24 months or 3 months post that 2-year period. So our primary objective is looking at the feasibility. Another aspect of the feasibility is the acceptability to participants, and also the acceptability to staff. So there will be sort of staff interviews along the way. The acceptability is assessed by some qualitative interviews, rather more than sort of the measuring aspect of our study, and by sort of participation in treatment. And our secondary objectives are looking at the safety, so looking at all the adverse events in the study, seeing how many have occurred, etc., the cost. And then we'll be looking at mainly markers of changes in their sort of non-prescribed opioid use, changes in other non-prescribed drug use, measuring things like quality of life, mental and physical health, social connectedness, well-being, and changes in crime. So the people that we have been looking for are generally aged 21 to 60, with a minimum of 5 years of sort of opioid dependence and some form of current physical dependence on opioids, using the ICD-10 criteria, roughly. They've had to have previous access to treatment of some sort, but it's not really sort of set as to how long ago or how much. We do prefer if you're injecting opioids more than sort of 3 times a week, so 4 or more times a week, really. And potentially some evidence of harm from opioid use. So majority of people who are still using are engaged in some sort of crime or other activity, such as sex work. They generally have other health conditions that are potentially not being addressed, or milder mental health conditions such as depression, anxiety, or issues with social functioning, even getting to appointments. Those sorts of things are quite difficult for many people when they're still in the midst of using. We need people to be able to provide written informed consent. Oh, hang on, what's going on? Oh, yeah, that's it. That's our last inclusion criteria. Our exclusion criteria, there's sort of quite a lot here, but the wording, a lot of wording, but not that many sort of points really. So anyone who's pregnant or breastfeeding or planning to become pregnant, generally sort of excluded from many trials. In this one particularly, we can't really sort of not aware of the effects of hydromorphone. So if somebody did become pregnant, we probably have to transfer them over to methadone if that's what they're already on, or continue the Suboxone if that's what they're already on. Any sort of advanced medical conditions, particularly advanced liver disease, severe chronic airflow limitation, or any other sort of severe medical condition, potentially epilepsy, as one of the adverse events can be seizures, mainly with diacetylmorphine. We don't necessarily exclude people, as I said, with mild sort of mental health conditions, but if there's some form of more severe psychiatric disorder, such as particularly acute psychosis, uncontrolled schizophrenia, or severe mood disorders, suicidal intent, then particularly at the time of assessment, that would exclude them from the study. Any medication that may interact with hydromorphone, mainly monoamine oxidase inhibitors, type of antidepressant, which not many people are on these days. That's okay. Previous adverse reaction to hydromorphone. Again, we haven't had many people express that as a concern. And any issues that make it difficult for them to complete the consent. Even with an interpreter, if language is a barrier, that would be a difficulty when it came to, say, overdose management. So unfortunately, at this point in time, they're excluded. So the study procedures, participants self-administer their hydromorphone, either intravenous or intramuscularly. And they can have it up to twice a day under direct observation by nursing staff. If they're not already on methadone or some form of OAT, then they need to start methadone for a week prior to starting hydromorphone, or with methadone, if they're already on it, just sort of 3 observed doses before commencement of hydromorphone. Hydromorphone starts quite a low dose, only 10 milligrams, and can increase each dose by 10 milligrams, with a range of between sort of 50 to 400 milligrams per day. It was proposed with a maximum of 200 milligrams per dose. We've probably sort of seen most people reach sort of 100 milligrams fairly quickly. I think we have a couple, maybe 1 or 2 who's sort of on 70 and sort of happy-ish on that dose, but majority of people probably around about 120, 130 milligrams twice a day. One person is up to about 170, 180 milligrams twice a day. What we sort of have found, though, some people on those high doses probably do get a little bit more constipation. The other issue is that in terms of the volume of the dose, it comes in 50 milligrams per mil. So the higher you go, the larger the volume that people inject, which is generally a lot more than the sort of usual 1 mil that they're used to injecting. So that's a little bit tricky as they go up. And intramuscularly, the higher the dose, generally people will have to sort of inject in the gluteal area or leg area rather than the arm. They have to have methadone or other OT prior to their injection of hydromorphone. As I said, some studies overseas, methadone has been something they could sort of choose to have if they didn't think they're going to come back for afternoon dosing or an overnight dose. Some other studies, methadone was part of it, but in our study, methadone or some other OT is necessary. The injection has to be in their upper limbs only, which, you know, it's not great for some people who love injecting in their neck. That's their only vein, but for safety reasons, we need it in the upper limb. So if they can't find a vein within their upper limb, then they need to inject intramuscularly. And there's a fairly short dosing period to try to sort of get people through the clinic in a timely fashion. So only roughly about sort of 5 minutes to inject. But it does sort of still take about sort of 5 to 10 minutes for the medication to be prepared, 5 minutes to inject. So each dosing episode at a minimum is sort of almost 15 minutes. And then there's generally another observation 10 minutes after their dose or 15 minutes after their dose. Probably, you know, people do need to sort of allow half an hour, 40 minutes per injection. And at 24 months, if they haven't already done so, participants will need to be transferred to some form of a standard OAT. In terms of our recruitment, we've been recruiting since early April, and we have up until sort of the end of September, technically, to recruit. When the trial was discussed, it was hoped to recruit people from MCIC, KRC, other services. That's largely where the bulk of our participants have come from. Rankin Court has a number of clients who've joined the study. Often those clients are also co-clients of MCIC as well. So we need a minimum of 20 and maximum of 30. Those participants that drop out in their first year of treatment do have their place kept open for about 3 months. How people are getting onto the study is generally they have a pre-screening assessment with our trial nurse, and then they're given an information sheet and often an appointment with the medical officer at least 24 hours after that discussion, so they've had time to digest the information in the information sheet. And then when they see the medical officer, which is me, they have their consent to participate in the study signed, and then sort of an assessment to further assess their eligibility. Once they're sort of eligible, we do a baseline medical history with topics such as medications, discuss contraception for female participants and male participants, as well as a basic examination. What we do need as a sort of a mandatory test is a baseline urine drug screen and urine pregnancy test. We were doing some baseline pathology, but for some participants, we've sort of found this is a little bit difficult in terms of their venous access. So if we can, we'll sort of offer some baseline pathology. At a minimum, we can do HIV and hepatitis C testing through a dry blood spot test. If they're not already on our OAT program, then we'll need to complete the regulatory paperwork for that as well. In terms of data collection, which I'm sure you're all terribly interested in, we will be looking at the number of days of injectable treatment, the number of days of receiving just oral medication only, number of missed days, and we all get all this information from their dosing records, their cards, and this gives us a really good picture of their retention in treatment. And then, as I mentioned, actually, this is the further sort of quantitative research interviews done independently by a UNSW researcher, looking at some of the numerical measures of quality of life and drug use. And these are done at baseline 1 year and 3 months after their last hydromorphone. And then we have these qualitative interviews, so more discussions around how people are progressing on the study. So they're semi-structured, tap into what's the sort of positive and negative experiences of participants, They talk a little bit more freely in that interview. Any other sort of negative issues, any sort of stigma associated with the trial, how they've sort of progressed in their sort of treatment journey, other sort of practical issues and other themes may arise in those interviews. And again, they're generally done about 3 times throughout the study, not always with the same participants. So hopefully we'll get a mix of feedback. So also to try and sort of see what the acceptability is like for other non-participants. So we'll hopefully interview some clients going to Rangan who are not on the study, but we'll also be interviewing staff and how they've found the integration of FOPiT into a standard opioid treatment program. The participants are offered general care as they would be in any other OAT program. So I see them at least every 3 months. There's some little bit more regular medical reviews as per the trial, but not generally too onerous. And actually we sort of found that some of the clients want to sort of see a doctor a little bit more to achieve a few things such as housing or a few medical issues they haven't really addressed. And as per other OAT treatment programs, they'll meet with their care coordinator regularly during the study and every 3 months. In terms of adverse events, we know that opioids can have severe adverse effects, such as respiratory depression, but also seizures. Generally, we think from the sort of hypoxia. Other adverse events: constipation, nausea, vomiting, dizziness, low blood pressure, dry mouth, sedation. Obviously this is a concern when setting up the trial, so we have engaged with the local clinical emergency response team, CERS team, and sort of develop protocols around overdose management and monitoring, and these are constantly being evaluated. Now that we've sort of had 3 months of people injecting, hopefully we can sort of wind that back a little bit in terms of how much observation we need to do, but certainly we need to be concerned around overdose still. Saying that, the studies that have been done show that respiratory depression was observed in about 1 in 6,000 injections, and seizures about 1 in every 12,000. So seeing that sentence gave me some relief. And often the overdoses and seizures are more common with Hydromorphone and not less common with Hydromorphone. These sort of adverse events generally occur pretty quickly after injecting, so monitoring people particularly closely in, say, the first 5 minutes and up to 15 minutes is advisable. Luckily, also another sentence that I liked reading was no deaths have been observed attributable to prescribed COT medication. And so this is actually the last slide. I said I'd probably be a little bit shorter than 30 minutes. So our first participant was recruited on the 27th of April. We've got 20 participants currently recruited, age range of 28 to 58 with an average of 45, which is, I think, pretty much close to the average age of people injecting drugs. Similarly, I think our sort of gender balance is fairly similar: 55% male, 40% female, 5% transgender. 5% of our clients have identified as Aboriginal, and 35% identifying as lesbian, gay, bisexual, transgender, intersex. I thought that our numbers of people already on OAT is probably higher than I expected. I thought we'd probably have a few more people coming forward who are not already on OAT, but interesting to sort of see that so many people are already on OAT and still injecting regularly. So 65% on some form of OAT at enrollment, mainly methadone, 90%, and 1 client on Suboxone and 1 on Buvidal. So yeah, so far no major adverse events, no overdoses, touching something vaguely looking like wood, and a number of different experiences. Some people one person just didn't like it at all and has dropped out after only one dose. Somebody else, very difficult to engage in terms of their methadone and would much rather prefer to inject in their neck than intramuscularly. I think that's part of the issue for that participant. And somebody else who did quite well for a number of months, but they were working previously sort of a chemist for the OAT, coming back to a public clinic for OAT, sort of really ground them down a bit, I think, even with the offer of free injectable treatment. So currently have sort of 17 sort of active participants injecting, most of them still coming twice a day. It's felt that they'll sort of drop off to once a day. I'm not quite sure when, what point. So as I said, still sort of early days. And yeah, a lot of positive stories have sort of come out of it so far. You know, many people have sort of started to achieve some goals which they sort of just haven't really done while being on OAT. One client's just got housing, actually another client's just got a job. Some of the small things have been really interesting, like people saying that, you know, they've got enough money to actually buy food, or they've got enough money to buy a washing machine. Things that I just sort of haven't really thought of. Or another participant said that they were really looking forward to being on this because they wouldn't have to sort of worry about, you know, what they're going to do to score heroin every day. They might actually be able to make an appointment to something like, you know, keep a doctor's appointment and follow up some of the medical things, because heroin always comes first. So, you know, if you need to score heroin for that day and then all of a sudden you get a call, so I've got to go get it, then you'll miss your other sort of appointments. So I don't know, I'd sort of forgotten some of those things, actually. So this has been a good little wake-up call for me as well around, you know, really what sort of happens when people are actively using. And that's it.
Thanks very much, Craig. I'm sure, well, I have lots of questions, and so I hope other people will have lots of questions too that we can pepper you with. But firstly, thank you for a very interesting talk and update on how things are going with the study. If I can sort of ask a two-part question.
Sure.
To start with, and I encourage everyone else to put their questions in the chat. What was the average dose of methadone, sorry?
Average dose of methadone that people are on? Look, none of this has sort of been analysed yet. All that stuff that I've put forward is very informal. Probably the highest somebody was on was 140. Oh no, sorry, 120. Probably sort of 50, 60, 50 to sort of 80. The 1, 2, 3, 4, 5. So there's 5 that are sort of only just sort of started and they're sort of sitting around 30, 40. Some of them are reluctant to go up on their methadone because they want to feel the hydromorphone. And some of those that have been on a higher dose, say 80-ish to 100, they've wanted to come down a little bit to sort of feel the hydromorphone. They don't quite sort of get the same euphoria that they might from heroin. So it's sort of different, you know. In one day, like one client's going, oh yeah, I'm really enjoying it, I'm getting the cotton wool effect, and then the other person's like, no, I'm not getting anything. But they were saying they're not getting anything from it, but they still actually hadn't used any extra heroin in the sort of the 2 weeks prior. So with the people sort of coming down, we've sort of said, look, okay, they can probably come down to about 60 and sort of see how they go. We'd still sort of aim to get people around, you know, an optimal dose of methadone, like 60 to 80. For instance, there's another participant who hadn't been on methadone for 30 years, and she is really keen to stop injecting. Seems like she's got very good access to heroin, hasn't needed to worry too much about money, no legal issues. So this time she really wants to get off heroin. So she's actually seeing this as her way to do it. And I mean, she's quite sort of keen to go up on a methadone, so she's about to sort of hit 80. And actually, once she sort of hit 60, or maybe 70, actually 70 methadone for the first time, I think in about 3 or 4 weeks, she stopped having her sort of evening dose of heroin, which she's actually a little bit surprised about. She went, "Oh, I don't feel like I need it." And she's actually only coming once a day. So, you know, it's certainly the high dose of methadone is better if we can sort of get people up to that. I think what people are worried about is how do they, when they want to give up their afternoon dose of hydromorphone, they'll potentially have to increase their methadone by 20 to 30 milligrams, depending on what dose they're on, or, you know, coming off the hydromorphone later down the track. So, you know, we've got time to sort of fiddle with people's sort of doses and see what they want to do.
Well, that's interesting that you do mention that. I'll save the second part of my question because Leona has jumped on with sort of, you've touched on the answer there already, but I think it's worth formally discussing. So she said, she's asked, what is if the OAT is already on its highest dose? So I guess you're talking more about patients on PIP because we don't have a ceiling for patients on methadone. How do you transition off? I'd like to hear about both actually, for patients on methadone and for patients on PIP.
Oh, look, I don't really have the answer to that, to be honest. So, I mean, you know, there was potentially somebody who I knew was on 200 milligrams of methadone who I thought might put their name down for the study and they didn't, luckily. So it's quite nice to have a little bit of leeway as to where people can sort of go.
You can go beyond 200. You just need an authority to do it.
Yeah, so you could. Yeah, so you have to sort of do a lot of monitoring and ECGs and trough levels and all of that sort of stuff to try and sort of go above a certain dose. There's somebody on Buvidal who's on 128 of Buvidal. I mean, we've got a little bit of wriggle room there for them as well, potentially. So, yeah, I don't. I mean, hopefully somebody on that sort of dose is not using too much on top, but yeah, we'd have to investigate how to go above 200 if need be.
Well, I guess with buprenorphine, if you have got somebody on a maximum dose, your hands are somewhat tied. I guess one alternative would be to look at a different arrangement. So if they were on the injection to see whether, I mean, but then that's
you can transfer them to methadone potentially as well if they're on buprenorphine. It's not working for them. I mean, a lot of people don't really want to do that. I mean, people still sort of want to be off methadone. I think some of them, you know, they sort of see this as an ultimate goal as well. So, you know, sort of meeting everyone's expectations of what this might provide. I mean, I don't know if we're always going to do that. But certainly I've talked about, you know, if people are on a stable dose of methadone, looking at, you know, transferring to buprenorphine and Buvidal via the, you know, Bernese method or our other sort of inpatient methods, which could be an option for them.
And I guess then I'd probably a second part of that question then. So if you've got a patient on hydromorphone, I mean, it's a roughly sort of 5 to 6 to morphine, and then another. So hang on, I'm trying to get it right. My own
dose conversion.
No, then I've got to divide by.
Yeah, I don't know.
It gets messy, doesn't it?
Yeah, we actually do have there is sort of a dose conversion table in the protocol. I don't think it's quite as particular as what you and I have discussed at one point. So I think what you and I discussed seemed like the doses were a lot higher that they might need. I think it also depends. So one of the clients, the gentleman who's on 120 of methadone, he quite early on in the study went on a holiday and wanted to transfer his methadone, but we can't transfer hydromorphone when somebody goes elsewhere. And they said that they went from 120 to 140 of methadone in that time and were actually okay. And, you know, again, they're on holiday, they're having a really good time. I think he said, I had a little bit of extra quetiapine. He planned to sort of take some heroin with him, but didn't, and sort of didn't need it in that time. Yet when he came off the second time, I think was experiencing more withdrawal symptoms, but again, didn't sort of really go above 140. So it was actually when they came back from the holiday, went back down to 120. So we sort of had a little bit more room to move with their methadone. So, again, I think it depends on what's going on in someone's life a little bit. Surely there will be some physical withdrawal, but, some of the other methods, distraction and et cetera, sometimes work as well for people.
I was sort of in my head, I've roughly got the figure of if you were going to convert them over of about 1.5, which I don't know, that seems like a lot if you've got patients on sort of another 40.
Yeah, no, I don't look at it according to the table in the protocol, which I haven't confirmed where they got that from. It's not that much.
Okay, all right, so it's a bit less, which
Yeah.
is probably fair enough. I'm probably, methadone's a tricky beast, and you're probably better off starting lower than going higher. Just on that,
sorry, Chris. 40 to 60 of hydromorphone. An additional methadone that day is only 10 milligrams. So if they're on sort of 145 to 200, it's an additional 25 of methadone. So I think that's probably as a starting sort of dose. But I don't think that equates to some of the conversions you've done in the past.
That's all right. And I mean, do you anticipate any? I mean, well, I guess with the clinical trial, I guess there's no choice for the patients. But do you anticipate patients would be, there's often a resistance to come down on dose. Do you anticipate that the majority of your patients would like to do this? I mean, you've sort of highlighted that this is, something that people are ideally doing for 6 months and then, stabilizing, getting back onto one form of treatment in the form of methadone or buprenorphine. Do you anticipate that when it comes to, if this becomes a real world thing, you have the benefit of the trial, you can say, trial's finishing, I can't keep prescribing this for you, in the real world, that might not be so easy. Do you anticipate most people are going to want to stay on this or not?
Look, I've been told no, in that the idea of this is to sort of medicalize it and almost make it very clinical and very boring. I sort of do think that not many people want to come twice a day to a clinic, particularly for the long term. So look, I'm not 100% sure, to be honest. I guess we'll see what happens with our sort of cohort of people who sort of left with us at the end of the trial. It gives a little bit of an indication, maybe, as to what sort of people want to do. But, certainly, having sort of people coming here, being able to sort of give them something that's safer to inject in a safe environment means they're not, involved in crime. It's, it's the principles of methadone taken a lot further. If that means they are coming a little bit longer than what, 2 years, maybe great. But with the ongoing, there probably has to be some sort of time limit for people. So from a funding sort of point of view. So
yeah, then I would anticipate that.
I don't know. I don't know if people will be coming for 2 years. I'm not sure.
No, I get the sense it'll be a bit like anything where it's about the conversation at the start, not the conversation at the end. So it's probably about, we're going to try this for X amount of time, and if that's working well, then we'll do this, and if it's not working well, we'll do that, and then if and those.
But I do think the confines of the clinic and time limits and those sorts of things are, at a certain point, people will become a little bit frustrated by.
Absolutely. Another question from Leona. She's asking if she can still refer patients who meet the inclusion criteria, even though you've recruited enough, just to see, this might, to gauge how many people are interested.
Yes, they're still open to receiving names, names of people. So we sort of get an idea of, number of people interested.
Thanks for that. And then, good, I get to ask another question. The study is, in your initial protocols, and is for treatment resistant. Yet we seem to have almost a third of patients sort of newly initiated. Is that is that going to be a
newly initiated to?
Yeah. So in my head, a patient the appropriate. I'm not. Please don't, this is not meant to be just as a criticism. It's a genuine question. Patients who failed treatment in my head are those that have tried, buprenorphine at a maximum dose, or tried methadone at a dose of at least X. I don't know what X is. If we're taking people who've only been on it for a few days, is that a treatment failure? That's that. Yeah, I don't know if that's a question or a statement. Then your thoughts?
Yeah, so it's not, I guess, so clearly defined in the protocol, and I think other studies have had difficulties recruitment because it was too rigid in its definition. So there are people who are. I thought we would have had more people coming forward who are just not on a treatment program at the moment, but had been on them in the past and just not retained. As I said, I'm a little bit surprised to a degree that a lot of the people have come from current OAT programs, but certainly those people. It's also difficult to. They'll tell us how many times a week they're injecting, and if they hit the right number, then that sort of includes them. We don't really have a way of knowing that to a degree either. A little bit of collateral, say, from prescribers or case managers assist us with that. Certainly people being referred from MCIC assist us with that. Urines don't really assist us with that if we've only got one when we're sort of seeing them. Knowing their sort of past history from their prescribers or case managers at MCIC has certainly sort of helped try to sort of get a selection of people that are a bit more treatment resistant. The other thing is some clients are not telling us that they're treatment resistant either. They tell us that everything is fine, and then all of a sudden they find out about this trial, and it's like, oh, I am injecting every day. So that's a sort of a tricky one to assess a little bit.
No, look, it's a challenge, and I guess what's interesting as well, and I guess if I can, is what I'm hearing is this is probably not going to, and not that I'm suggesting it's ever a plan to, but probably not going to replace the current first-line treatments. It's still going to be that adjunct. It's not going to be, I use heroin,
No, and it doesn't, as I said, I don't think in the European, certainly the UK trials, the methadone was always given. In the North American ones, not so much. Not quite sure what their sort of current standards of treatment are. I think in the Vancouver, they still can probably solely have an injectable treatment with methadone or some other long-acting opioid treatment as a backup if they need it. Some of the, I think I read something yesterday in the Swiss sort of treatment now, they actually were giving oral diacetylmorphone to some of their more stable clients as takeaway doses during COVID. So, there's still, there's a lot more that has been done in sort of injectable opioid treatments in other countries. This is really just the beginning of what we could offer here potentially.
Excellent. All right. Well, I don't think we have any more questions. So that means you must have covered everything thoroughly. And we, of course, are interested to hear the results, if and when they come through, and also if there are further plans in the pipeline to roll this out as something, as a treatment, a second-line treatment, or so forth, or rescue therapy for people who have this. And I think it would be, personally, I'm very excited about this moving into the future. And, you know, it's obviously resource intensive, so it may be something that is more metropolitan than and not something that's.
Yeah, I mean, it's sort of, well, yes and no. I mean, when we sort of started the trial, you know, we have a sort of dedicated area that's off the waiting room of Rankin, which, you know, again, it'll be interesting to sort of see what other, you know, non-participants think of that. When it did start, we were using a clinic room, which we sort of had to do by choice because our area wasn't ready. And I mean, that was sort of a reasonable thing to do for a small number of clients. So I guess the idea of this is how it can be integrated into a current opioid treatment program. So if the numbers are sort of small, you know, potentially it could be done in, you know, a clinic room. But just in terms of, depending on where it is also done, you know, if it's a hospital setting or community setting, having sort of policies and procedures in place for overdose management and, you know, storage of hydromorphone. A lot of those things are also other, you know, considerable hurdles to get over, which could be restrictive for more rural areas, but certainly, you know, in terms of a space, it sort of could be done anywhere, really.
Yeah, well, I think that will be the next challenge if this does become is how to roll this out in, you know, it's easy in Sydney where there's good transport links and you know, resources and so forth. It's going to be much trickier in the more regional and rural areas. So
Yeah.
but nonetheless, still plenty of interest and everything else that goes along with it.
And unfortunately, I was just talking to the nursing unit manager, Anna, and I said, oh, it would have been good for her to be on here to talk about some of the nursing experiences, but unfortunately, she's working in FOPiT at the minute.
No, and look, I imagine there will probably be some qualitative data
Yeah.
that comes out of this as well.
Yeah.
Thanks for, well, I don't think we've got any more questions, so join with me in thanking Dr. Craig Rodgers for a great presentation on the FOPiT trial and injectable heroin and hydromorphone as potential second-line options for opioid dependence, something that we will be definitely seeing more of in the future. And look, hopefully we will see you all at the same time, 2:30 next Monday afternoon. Look forward to seeing you then. Thanks, Greg.
Thanks, Chris. Bye.